First of all, I'd like to thank the Orthopaedic department in Benha University for the kind invitation, Professor Mohammed Al-Ashab and Dr. Mahmoud Abu Zaid. Very glad to be among my professors and colleagues. And I'd like to thank Dr. Haberkamp for the very rich and informative lecture about the osteochondral lesions. I'll talk about the arthroscopic management of chronic ankle pain after trauma. We'll try to give a broad spectrum view about how we can use the scope for the causes of persistent pain for a long time after ankle trauma. If we have a quick look at the history of anterior ankle arthroscopy, 1931 was the first publication about this type of arthroscopy. 1993 was the first systematic evaluation of the ankle by scope. 1972 and 76 was the first publication of clinical outcomes and complications after the first series of ankle scopes ever. In 1988 was the development of invasive ankle distraction methods that depended on pins fixed to bone to achieve ankle distraction and improve visualization. That expanded the therapeutic and diagnostic indications of ankle scope, but was later on replaced by the non-invasive distraction to reduce the complications. In 1997 was the introduction of the dorsiflexion technique that Dr. Haberkamp talked about to further reduce the complications of anterior scope. And in 2000 was the description of the classic two-portal hindfoot endoscopy or posterior ankle arthroscopy. When we're doing an anterior ankle scope, we put the to improve visualization, either the distraction technique or the dorsiflexion method. The distraction technique widens the joint space and provides space for instrumentation. It provides excellent visualization of both the tibial plafond and the talar dome, particularly the central and most posterior parts. But on the other hand, it stretches the anterior capsule, bringing the neurovascular structures closer to the joint, and increases the risk of their injury and reduces the anterior working space. So most of surgeons now rely on the dorsiflexion method that increases the anterior working space, allows safe and greater access to anterior joint space using larger instruments, and it allows better visualization of the gutters, but sometimes it's difficult to reach the most posterior regions of the talar dome, like we discussed with the previous lecture. When distraction is needed, the invasive distraction is no longer a necessity. Non-invasive distraction is usually sufficient, either by a distraction device fixed to the operating table, or alternatively, a sterilizable strap is attached to the ankle and fixed to the waist of the operating surgeon so that he can apply distraction whenever he needs by leaning backwards. And he can also use the distraction and dorsiflexion alternatively by just relaxing the traction and leaning forward with the abdomen to put the ankle in dorsiflexion to increase the anterior working area. Even if the re-sterilizable strap, the professional one, is not available, we can use just a sterile compression bandage in this barrel sling technique to achieve the desired distraction. When placing portals for anterior ankle arthroscopy, first we start with marking the important anatomic landmarks. These will be the medial malleolus, the tibialis anterior tendon, the anterior joint line, the peroneus tertius tendon, and if not present, which is about in 10% of cases, will be the extensor digitorum muscle and the lateral malleolus. And it's very important to mark the lateral branch of the superficial peroneal nerve or the intermediate dorsal cutaneous nerve. This can be better visualized by plantar flexing the ankle and flexing the fourth toe. The joint is distended with a sterile saline, and the intra-articular injection is confirmed by both backflow and a slight passive dorsiflexion that happens in the ankle during injection. Usually we start with the anteromedial portal because no major neurovascular structures are related to this portal, just medial to the tibialis anterior tendon, stab incision, through the skin only, then a mosquito clamp is used to widen the soft tissues, and then the joint is entered. When we are performing the anterolateral portal, it's usually made under direct visualization from outside in to avoid injury of branches of the superficial peroneal nerve. So trans-illumination of the scope inside the joint can help avoiding the branches. And the safest position for the anterolateral portal will be just lateral to the peroneus tertius we mark it on the scan. For the classic posterior arthroscopy, we place the patient in prone position with the ankle overhanging the table, and then we mark the both malleoli and the medial and lateral borders of the Achilles tendon. Then a line is drawn parallel to the sole of the foot with the ankle neutral position. We start with the posterolateral portal just above this line and just lateral to the Achilles tendon border. Then a mosquito clamp is used to widen the soft tissues. Then the scope is introduced aiming towards the first web space. Then the posteromedial portal is created at the same level, and the mosquito clamp is introduced just perpendicular to the scope shaft, touching it, and then sliding slowly distally until the scope or the shaver blade is visualized. And we start creating the working area very slowly from lateral to medial to achieve the first most important step, which is exposure of the flexor hallucis longus tendon, because the posterior neurovascular bundle is located medial to this. So the safe working area for the hind foot endoscopy or arthroscopy will be the area lateral to the flexor hallucis longus tendon. So during exposure with the shaver blade, passive motion of the big toe will help the identification of the tendon and then confirming being on the safe side. Complications of ankle arthroscopy overall are reported to be 7 to 9% in the literature. Most common is the neurologic complications, representing about 50 to 80% of the overall complications of ankle arthroscopy. Most common is the injury to branches of the superficial peroneal nerve, up to 8.3%. Other neurovascular injuries can involve deep peroneal, saphenous, sural, or tibial nerves, or the incidence of deep vascular thrombosis or pseudoaneurysm. Soft tissue complications, being a superficial joint, can involve infection and sinus tract formation. Other less common complications will be injury to tendons, ligaments, or articular cartilage. So now we proceed to the main scope of the talk of how can we use the scope to treat causes of chronic ankle pain after trauma. These are the most common indications for performing a scope after trauma. One of them, a very big category, the osteochondral lesions, has been quietly thoroughly covered in the previous talk, so we'll keep just the osteochondral lesions to the end of our talk, or just have a small idea about it. But the other very important indications are the ankle impingement syndromes, the chronic lateral ankle instability, ankle arthritis post-traumatic type, and the arthrofibrosis. So ankle impingement syndrome is defined as a mechanical pain secondary to binding or friction of pathological osseous or soft tissue structure. So both anterior and posterior ankle impingement can be either bony impingement, soft tissue impingement, or both. For anterior ankle impingement, it can occur in the anteromedial, anterocentral, or anterolateral compartments of the joint, and it can also occur in the syndesmotic area. For soft tissue anterior impingement, it occurs when a scar tissue inside the joint gets insinuated between the tibial plafond and the talar bone, or the very distal fascicle of the anterior inferior tibiofibular ligament, or the Bassett's ligament, comes in contact with the talar bone. We know that chronic lateral instability increases the chance of this band of the ligament coming in contact with the talar bone. And we used to consider this a persistent cause of pain and resect it in all cases. But nowadays, it's considered a normal finding to find this band coming in contact with the talar bone during arthroscopy, and should be excised only if very prominent, or if it gets bent over the talar bone during the maximum degrees of dorsiflexion. For osseous anterior bony impingement, it occurs either due to chronic ankle instability or as a result of repetitive blunt microtrauma to the anterior aspect of the ankle. This is an example of the anterior osteophytes resulting from chronic ankle instability. They usually involve the entire tibial plafond anterior edge, and they have a barrel peak appearance, while those resulting from repetitive microtrauma will be located at the most central and anterior areas of the tibial plafond and or the tailbone. Asymptomatic osteophytes can be frequently found in runners and soccer players, but when symptomatic, the patient will have a pain on the anterior aspect of the joint, localized tenderness over the impingement area, some decrease in the range of dorsiflexion due to impingement, and the localized tenderness can be sometimes accentuated by passive forced dorsiflexion of the ankle. Plain X-rays and CT will help localize the osteophytes and determine their size. But if no osteophytes are detected, then the diagnosis of soft tissue impingement is made. If we want to confirm the diagnosis of soft tissue impingement, one method will be ultrasonography, inexpensive and reliable. One other method will be the magnetic resonance imaging, but usually we do the MR arthrography to get higher sensitivity for detection of localized soft tissue masses than the ordinary MRI. The examiner also can inject a local anesthetic inside the joint, and the temporary relief of symptoms after injection will confirm the presence of intra-articular pathology. It's also very important to note that some osteophytes on the anteromedial aspect of the joint at the notch of Carty might not be visible on the lateral radiographs due to the higher level of the lateral tibial plafond. So the oblique anteromedial impingement view, in which the ankle is rotated 30 degrees externally and the beam is radiated 45 degrees craniocaudal, is very important because a patient with a normal perfect lateral radiograph can have very large osteophytes on the anteromedial joint, up to 7 millimeters on the anteromedial impingement view. This is an example of the anterolateral soft tissue impingement. This is the low-lying fascicle of the anterior inferior tibiofibular ligament. It's first resected with a punch, and the resection is completed with the Schaefer blade until the triad of tibial plafond, the talar dome, and the fibula is visualized. This is the anterior bony impingement. That's a talar neck osteophytes moving with the passive motion of the talar dome. It is resected using the acrominizer until full resection is achieved. This is the anterior tibial plafond osteophyte. It's also resected gradually from the proximal capsular attachment to the level of the joint line until complete resection is achieved. Here is after full resection, and we can see the classic fan tract lesions that can occur on the talar dome as a result of repetitive friction with the tibial plafond osteophytes. In posterior ankle impingement, it follows either an acute hyperflexion injury of the ankle or repetitive activities that involve hyperflexion of the ankle. This results in insinuation of normal anatomic structures like the osteogonal or an enlarged posterolateral talar process between the calcaneus and tibial plafond during hyperplantar flexion. So it's frequently seen in ballet dancers, downhill runners, and the posterior impingement of the ankle can also be a soft tissue impingement resulting from impingement of the posterior joint capsule, the intermalleolar ligament, sometimes the posterior inferior tibiofibular ligament, or the FH tendon itself. So the patient will have a pain along the posterior joint line that can be accentuated by the hyperplantar flexion test. On hyperplantar flexion lateral radiograph, we can see the compression of the osteogonal or the enlarged posterior talar process between the tibial plafond and the calcaneus. MRI can confirm the diagnosis by showing an increased signal intensity on the fat suppression views at the site of the impingement, which can differentiate the normal findings of osteogonal from those pathological occurring during posterior impingement. This is the resection of the os trigona. This is the mobile os. Posterior ankle arthroscopy. Soft tissue attachment of the ossicle are resected either with a punch or carefully with a knife. Also release of soft tissues around the FHL tendon, and sometimes tenosynovectomy for the tendon is required, as the tendon might be a little bit frayed from repetitive friction with the ossicle. Then a small arthroscopic osteotome is used to separate the ossicle at the site of the pseudoarthrosis, and the fragment is delivered out of the joint, followed by one more time inspection with the FHL tendon for any damage. One more indication to scope an ankle after trauma is the chronic lateral ankle instability. We know that the ankle instability depends on the anterior talofibular ligament that runs from posterolateral to anteromedial. It controls internal rotation and anterior translation of the talus. This is the weakest and most frequently injured one. The stronger calcaneofibular ligament runs from the tip of the fibula 30 degrees posterior to be attached to the calcaneus lead to the peroneal tendons. It controls the lateral tilt of the talus and calcaneus. It can be injured in isolation, but more commonly injured in combination with the anterior talofibular. Posterior talofibular is the strongest and needs very high injury to be injured. So patients with chronic lateral ankle instability will complain from recurrent episodes of pain and swelling. They can have recurrent acute supination injuries of the ankle. They can report even atraumatic giving way of the ankle or report an unstable ankle. So the diagnosis can be confirmed by the anterior drawer test or the varus stress test to confirm instability compared to the other side. Also, stress plane radiographs, either the varus stress or the anterior drawer stress, can confirm instability. 3 degrees of angulation and 3 millimeters of anterior translation difference between the injured and the normal side will be considered positive for instability. MRI also can be helpful in confirming the diagnosis. Axial cuts to evaluate the anterior talofibular ligament, and usually the coronal cuts to evaluate any injury to the calcaneofibular ligament deep to the peroneal tendons. So even in the open management for chronic lateral ankle instability, performing an ankle scope prior to any open surgery is mandatory step, because a very high percentage, 70 to 90% of patients with chronic lateral ankle instability will have an associated intra-articular pathology, either osteochondral lesion, loose body, anterior impingement, syndesmotic injury, whatever associated lesion. So it's not allowed to perform an open treatment for a chronic lateral instability without considering scoping the ankle as a step of the surgery. This is the arthroscopic classification of the ATFL injury. Also, one of the advantages of scoping the injured ankle. This is type 1, the distended ATFL. This is type 2, the fibular avulsion of the ligament. This is type 3, very thin anterior talofibular ligament with scar tissue. And this is type 4, absent ligament completely with walled malleus. So this is useful in choosing the surgical treatment method. Usually types 1 and 2 are amenable for ATFL repair, while types 3 and 4 usually need reconstruction. So if we have a look about the surgical treatment of chronic lateral ankle instability after failure of conservative measures, we are familiar with the repair techniques. One of the most common is the Rostrom-Gould surgery, in which there is retightening of the injured ligaments, and in the Gould modification there is augmentation by the extensor retinaculum to augment the repair. The reconstruction, anatomic reconstruction, is reserved for patients who failed previous repair, patients who have a very high body mass index. Also, patients with generalized ligamentous laxity will require reconstruction rather than a repair, and also for patients with a high labor occupation or a high-level sports activity. Recently, the arthroscopic repair of the lateral ankle ligaments has been described. It's usually done with 2 anchors at the distal fibula at the sites of attachment of the anterior talofibular and the calcaneofibular ligament. And then the sutures of the anchors are shuttled through the injured ligaments and retightened to achieve repair of the ligament and the proper tension. Arthroscopic rostrum technique also has been recently described. The landmarks, the distal fibula is marked, the anterior border of the peroneal tendons is also marked, the intermediate dorsal cutaneous branch, this mark, and the extensor retinaculum is marked about 1.5 centimeters distal to the fibular tip. The first anchor is placed arthroscopically and the sutures retrieved from the anterolateral portal. Then the two sutures are shuttled through the extensor retinaculum separately, this way. And the same is repeated with the second anchor at the fibular tip. And the two sutures also passed through the extensor retinaculum. So finally, we have two sets of sutures passing through the retinaculum separately. We do small step incision in between, retrieve all the sutures subcutaneously, and then tying the retinaculum in the proper tension to advance it or to proximally transfer it to the distal fibula. In 2014, also the anatomic reconstruction using gracilus autograft or arthroscopic has been described. It requires the additional anteromedial and anterolateral portals, but in addition, a sinus tarsi portal and a retromalleolar portal behind the lateral malleolus, through which a peroneal tendoscopy can be performed to assess the peronei for any injury and to clear the soft tissue anterior to them in order to perform the reconstruction. Then a tunnel is created in the fibula to retrieve the fibular end of the graft. The attachment sites of the ATFL and calcaneofibular ligament are cleared up, and talar and calcaneal tunnels are created at the anatomic sites. The technique uses a two-tailed gracilus graft. The fibular side will retrieve a cortical suspension device, and one of the limbs will go to reconstruct the ATFL, the other to reconstruct the calcaneofibular ligament, all arthroscopic. And I have looked up this paper about arthroscopic treatment in general for chronic lateral ankle instability, a prospective study for outcome in 286 patients. 115 patients underwent repair, 171 underwent reconstruction. The mean follow-up was about 9.6 months. Overall satisfaction was 8.5. The follow-up scores improved significantly between pre and post-operative. No difference between the arthroscopic repair and reconstruction, and complications in neurologic one 10%, and reoperation rate was 4.2%. So the arthroscopic treatment of chronic lateral instability is promising with preliminary good results, but further studies are required to confirm this. One more category in the chronic ankle pain is the post-traumatic osteoarthritis. Ankle osteoarthritis is less common than in the hip and the knee, and the post-traumatic type is responsible for about 2/3 of all ankle arthritis and is the most common etiology. So if we proceed to the role of arthroscopy, one of the known surgical measures to treat osteoarthritis of the ankle in a young patient who is not a candidate for arthrodesis or arthroplasty is the joint distraction technique or arthrodiastasis. In this technique, a ring external fixator, usually Lizarov, is applied and used to distract the joint progressively up to 5 millimeters. The key success for this surgery is the maintenance of a weight-bearing situation and keeping the distraction for a long time, because the treatment period can be extended up to 3 months. This is an example of the arthrodesthesis. This is the immediate post-operative X-ray with the narrow joint space and obliteration. And this is 1 week after the progressive distraction with the joint space distracted. The rationale for this surgery is based on the self-repairing techniques of the osteochondral tissue when unloaded. So we give a chance for the diseased cartilage to heal itself. And the main complications can be infections, neurovascular lesions, hardware failure, and damage to the ankle ligaments. But the main drawback is usually how to convince a patient to undergo this surgery and with the patient compliance. The role of arthroscopy in this surgery is that it can be a very successful additive maneuver. This paper compares the distraction arthroplasty alone versus when combined with arthroscopic microfraction. 96 patients underwent distraction only or combined surgery. The scores are higher in the combined group, and the combined group achieved a better radiological outcome than the isolated arthrodesis only. Another indication in the advanced osteoarthritis will be the arthroscopic ankle arthrodesis or the arthroscopic assisted fusion. The advantage is that we keep the soft tissue envelope, and so we have a higher and earlier fusion rates. It can be applied to ankles without major deformity. Any varus or varus deformity greater than 15 degrees will be a relative contraindication for the arthroscopic technique. This is the arthroscopic ankle arthrodesis, creation of the working space first, anterior ankle arthroscopy, then removal of the articular cartilage from the tibial plafond. This is all done through the dorsiflexion technique. No distraction was needed. And then denuding the cartilage from the talar dome using a variety of curettes and arthroscopic osteotomes, also from the lateral gutter or the inner aspect of the lateral malleolus. And after satisfactory denudation of all the articular cartilage, some abrasion arthroplasty can be performed to enhance the fusion rates. Maybe also some shingling of the subchondral bone using the arthroscopic osteotome. And then the wires for the cannulated screws are applied under fluoroscopic guidance. They will be seen coming through the joint with the scope from the tibial plafond to the talus. Their position can be adjusted if needed until a satisfactory position is achieved. Then the wires can be withdrawn to the level of the tibial plafond, and the focus of attention is how to place the ankle in a proper fusion position. Then the wires are advanced in the proper position under fluoroscopic guidance, and the cannulated screws are applied. So arthroscopic versus open ankle arthrodesis, this is a systematic review. A total of 7 retrospective comparative studies were included. The follow-up scores were better in the arthroscopic group. The union rates were similar between the two groups. Complication rates are higher in the open group. The reoperation rate was similar between the two groups. Hospital stay and blood loss less in the arthroscopic group, and no difference in the operative time in 4 of these studies. One more indication will be arthrofibrosis after trauma. Ankle stiffness, or what's called the frozen ankle, can be a disabling sequelae after ankle trauma. This can be the result of second osteoarthrosis of the ankle, osteochondral fractures with loose bodies, intra-articular malunion, fibrosis of the periarticular tendon and muscles, or post-traumatic adhesive capsulitis, the frozen ankle. Diagnosis depends mainly on the clinical assessment. Patients with frozen ankle will complain from painful stiffness of the involved ankle, recurrent episodes of swelling, and difficulty in navigating stairs or slope surfaces. Pain is mainly deep posterior pain. It's very important before performing arthroscopic arthrolysis for such cases to exclude the extra-articular contribution in the stiffness. So arthroscopic capsular release of the ankle joint is one of the indications for simultaneous anterior and posterior ankle arthroscopy in the same session. Usually, we start with the posterior ankle arthroscopy, exposing the FHL tendon, and then releasing the posterior capsule of the ankle joint to open the joint space, and then in the same session, anterior ankle arthroscopy to excise the second anterior capsule and improve the range of motion. This maneuver can improve range of motion immediately post-operatively allowing early vigorous mobilization after surgery with shorter rehab period owing to smaller stab incisions with arthroscopy and the minimal soft tissue involvement. One last indication is the osteochondral lesions. This has been quite extensively covered in the previous lecture. Just a broad idea, decision-making depends on age, degree of symptoms, activity level, and size and location of the lesion. For larger, more symptomatic lesions, either a reparative surgery, fixation, subchondral bone microfracture, or retrograde drilling. If the patient fails one of these maneuvers, or if the lesion is larger than 15 millimeters in the greatest dimension, or 150 millimeters square area, we can resort to OATS, osteochondral allograft, AC, MACI, juvenile pediatric transplant, or arthroplasty, as was mentioned before. The biological augmentation that was also discussed extensively through the PRP or bone marrow aspect. The subchondral bone microfracture is one of the most common techniques performed arthroscopically with very high success rate. OATS also can be harvested from the ipsilateral knee and implanted in the ankle with osteochondral lesion with very high success rate. So to summarize, a number of evidence-based arthroscopic techniques have been advocated to treat ankle pathology responsible for chronic pain after trauma, including instability, impingement, osteochondral lesions, and osteoarthritis. For anterior scope, dorsiflexion technique is usually sufficient in most indications, with minimal risk of injuring of the articular cartilage. Hindfoot endoscopy is recommended to address posterior ankle abnormalities. Complications can be minimized by thorough knowledge of the arthroscopic anatomy and systematic surgical approach. Thank you.
شكرا جزيلا اخينا العزيز الفاضل استاذ دكتور طارق بن نبيل على المحاضره الاكثر من رائعه دي. وهنبدا الدسكشن مع سعادتك مع اخينا الحبيب استاذ دكتور محمود ابو زيد، اللي بصراحه بذل مجهود رهيب في الكورس ده. يعني الكورس ده كله قايم على بتاع الفوت اند انكل، قايم على كتف الدكتور محمود ابو زيد.
ربنا يشكرك. احنا بنشكر حضرتك يا دكتور طارق على مشاركه حضرتك معانا، يعني كتر خير حضرتك. يعني محاضره بصراحه رائعه، محاضره رائعه، وبصراحه غطت الانكل سكوب يعني.
شكرا.
احنا بس احنا عاوزين نبدا نوضح لهم بس هو السيت سايز. انت حضرتك بتستخدم منظار عدسه كام؟ عشان هو في ناس كتير بتبقى يعني عاوزه تعرف يعني هو يستخدم منظار عادي ولا بيستخدم 2.7 اللي هو ريست سكوب، ولا بيستخدم ايه بالظبط؟
تمام. حاليا كل الناس
يعني
تقدر تبدا انكل سكوب بالستاندرد ارثروسكوبي ست العاديه خالص اللي بتستخدم في الني 4 ملم، وكل البيزك ارثروسكوبيك انسترومنتس، ويقدر يعمل انتيريور انكل سكوب بنفس الست بتاعت الني.
تمام. هو
يمكن زمان كان الستاندرد 2.7 خصوصا في بعض الانديكيشنز الاوستيوكوندرال ليجنز او كده، لكن دلوقتي most of surgeries can be performed with the routine 4 ملم scope.
تمام. يعني انا بس يعني مش عارف حضرتك متفق معايا ان احنا لما بنستخدم روتين سكوب الفيو بيبقى افضل، ان هو بيبقى لما بنستخدم 2.7 يعني يبقى فوكس على حتت صغيره، انما في يعني انما الروتين بتاع الني بيكون الفيو افضل. What are the criteria of ankle lesion amenable for arthrodesis either with or without arthroscopy?
So for arthrodesis, the main indications are mild to moderate ankle osteoarthritis. Ankle osteoarthritis Lee classification, Takakura. Mild to moderate type in a young patient which is refusing arthrodesis or not suitable for arthrodesis and will not undergo the selection criteria for arthroplasty. لو عندي عيان عنده advanced mild or moderate osteoarthritis وفي ناس كاتبه على advanced كمان، العيان very young age or relatively young age, he deserves a trial of arthrodesis if you can convince him to have الإزارة في رجله لمدة مثلا 3 أو 4 شهور. Results are very successful. صحيح بيحصل deterioration، في ناس كتبت إن بيحصل deterioration للريزلتس بعد 7 إلى 8 سنين، لكن at least it deserves a trial في patient بالكرايتيريا لأنه مفيش other option.
تمام. هو طبعا الدكتور طارق غطى كل الحاجه، فالناس ما يعني هو كاتب لحضرتك طبعا هو نايس سيشن. احنا متشكرين لحضرتك جدا يا دكتور طارق، وشكرا على وقت حضرتك المحاضره الرائعه.